Okay, good afternoon, everyone. Today I'm going to be presenting to you about my work regarding the influence of cerebrovascular disease on functional and structural network connectivity in patients with amnestic mild impairment and Alzheimer's disease. Now, the worldwide prevalence of dementia is, of course, on the rise, and it's expected to double every 20 years, as per new statistics. And in fact, within the Asia-Pacific region alone, the number of people living with dementia is expected to triple by the year 2050. So it's clearly a problem that deserves our time and attention. Now, Alzheimer's disease in particular is characterized by amyloid beta plaques and tau tangle deposition in the brain. We also find that memory loss is the key cognitive impairment that we find in subjects with Alzheimer's disease. And also, as per the network degeneration hypothesis, we find that the brain changes that occur in neurodegenerative disorders are not at random, but tend to follow brain networks. And in fact, we find that functional connectivity changes, metabolic changes, as well as gray and white matter atrophy in the brain in Alzheimer's disease tends to occur in regions that are key regions within the default mode network, and these include the hippocampus, the posterior cingulate cortex, the medial prefrontal cortex, as well as the precuneus. However, often Alzheimer's disease is not found by itself. In fact, 43% of all dementia cases in the Asia-Pacific region are thought to be comorbid for Alzheimer's disease and cerebrovascular disease. Now, if you talk about cerebrovascular disease, which is a group of conditions that affects blood circulation to the brain, there are multiple markers that we can use to detect it in the brain. And these include infarcts, lacunes, as well as white matter hyperintensities, which are seen as these hyperintense regions in the brain, which tend to be quite widespread and confluent in nature when you look at subjects with cerebrovascular disease or CVD, especially when you compare them to their diagnosis counterparts, but without cerebrovascular disease, and also healthy controls. But what really is the nature of the relationship between Alzheimer's disease and cerebrovascular disease? Well, as I mentioned earlier, the default mode network is the primary network that's affected in subjects with Alzheimer's disease, and we find that in terms of both functional as well as white matter structural changes. And often these alterations are associated with episodic memory. On the other hand, the executive control network is one of the key networks that is affected in cerebrovascular disease, and we find that again in terms of functional connectivity changes as well as widespread white matter changes in the brain. And often these changes are associated with executive function. Now, there are recent studies that have looked at subjects with comorbid Alzheimer's disease as well as cerebrovascular disease pathology. And one of the key hypotheses out there talks about the additive influence of cerebrovascular disease in Alzheimer's disease. Now, what this means is that it is thought that subjects that have both combined Alzheimer's disease as well as cerebrovascular disease pathology tend to be further along the disease progression rather than those that have either. However, not many studies have looked at functional as well as structural network changes in subjects with such comorbidities. So, our key aim was to understand whether the presence of cerebrovascular disease affects functional and structural network connectivity differentially in Alzheimer's disease and amnestic mild cognitive impairment. In fact, a recent study from our lab has indeed found differential neural network structural and functional changes in Alzheimer's disease with and without cerebrovascular disease, and this happened in the default mode as well as the executive control network. However, we find that this study, as well as others, have primarily used single seed-based approaches, and we know that networks such as the default mode and the executive control network tend to have multiple core regions as belonging to it. And so, instead, we wanted to use a multiple seed-based approach to assess the question at hand. And we also find that often, when you're using different seeds, you can find different functional connectivity patterns. So we wanted to assess this as well. So our key aim was to examine the region-based effect of cerebrovascular disease and the associations between network connectivity and cognition in subjects with Alzheimer's disease, dementia, and amnestic mild cognitive impairment using this multiple seed-based approach. So our key hypothesis regarding the Alzheimer's disease stage was that default mode network functional connectivity would be primarily found in the Alzheimer's disease subjects without cerebrovascular disease, whereas changes in the executive control network in terms of functional connectivity would be found primarily in AD subjects with CVD. We also expect that structural connectivity within the two networks would exhibit similar patterns. However, we do hypothesize that the AD with CVD subjects would be worse off in terms of their structural connectivity than their non-CVD counterparts. For the amnestic MCI stage, we expect similar patterns in terms of their network connectivity alterations as the dementia stage, but of course of a less severe or widespread nature. Lastly, we also wanted to look at the brain cognition association. And here, we predict that the default mode network connectivity changes would relate to memory deficits, whereas the executive control network changes would relate to executive function and attention deficits. We also expect that the presence or absence of cerebrovascular disease in the brain would also be related or influence the brain cognition relationship. So in order to assess our key hypothesis, we had 5 groups of subjects, which included controls, amnestic mild cognitive impairment, amnestic mild cognitive impairment with cerebrovascular disease, Alzheimer's disease, and Alzheimer's disease with cerebrovascular disease. We also matched the disease severity between the cerebrovascular disease and non-cerebrovascular disease groups. We then devised 4 key regions as belonging to the executive control network, which included the left and right dorsolateral prefrontal cortex and the left and right posterior parietal cortex. For the default mode network, we had 5 key regions, which included the left and right hippocampus, the medial prefrontal cortex, the posterior cingulate cortex, and the precuneus. We then carried out probabilistic fiber tracking as well as seed-based functional connectivity. We then classified the changes that we saw as either occurring within the default mode network, within the executive control network, or between the 2 networks. And the first thing that we assessed was the group differences in network connectivity. So the first thing we're going to talk about is the default mode network. And here we found for the hippocampus as well as the precuneus seed, we found similar temporoparietal reductions in frontoparietal functional connectivity. And these similar changes across CVD and non-CVD groups are represented in the signed colored circles here. On the other hand, for the precuneus seed, we found divergent changes between the CVD and non-CVD groups, such that subjects with AD subjects showed reductions in parietal functional connectivity, whereas AD with CVD subjects showed increases in parietal functional connectivity. For the medial prefrontal cortex seed, we found frontoparietal reductions in functional connectivity. However, for the AD with CVD subjects, we found increases in frontoparietal functional connectivity, again reflecting a divergence between the CVD and the non-CVD groups. Then we looked at the AMCI stage, and here we found that the AMCI with CVD subjects mirrored functional connectivity alterations as those occurring in the AD with CVD groups. However, the AMCI subjects without cerebrovascular disease did not show any group differences in terms of their default mode network functional connectivity compared to the healthy controls. Then we looked at the executive control network, and again, we found divergent changes that were related to the dorsolateral prefrontal cortex seed in the AD with CVD as well as the AMCI with CVD groups. And here we found frontal increases in functional connectivity. However, no such changes were seen in the AD-only groups. For the posterior parietal cortex, we found frontoparietal decreases as well as parietal increases in functional connectivity. And this was also seen in the AD with CVD groups, and we also found some frontoparietal reductions in the AMCI with CVD subjects. However, the AMCI subjects without cerebrovascular disease, again, did not show any changes in functional connectivity for the executive control network. The next thing we saw was that higher executive control network functional connectivity that we just saw was associated with higher white matter hyperintensity volume, which is a key marker for cerebrovascular disease in the brain. And this was seen at both the AMCI as well as the AD stage. However, this was not seen for the default mode network functional connectivity. So we postulate that perhaps such increases in executive control network functional connectivity could be representative of cerebrovascular disease in the brain. The next thing we looked at was structure connectivity changes, and we found that for the default mode network, generally the AD groups showed lower structure connectivity. However, the AD with CVD subjects showed even more widespread changes in terms of their structure connectivity compared to the non-CVD AD. Moreover, for the executive control network, when we compared the same diagnosis group, but CVD versus non-CVD subjects, we found that the AD with CVD as well as the AMCI with CVD subjects showed further reduced structure connectivity compared to their non-CVD counterparts, and this is shown by the red arrows here. And this was also seen for the internetwork structure connectivity in terms of the CVD versus non-CVD differences. And so we found that cerebrovascular disease subjects showed more widespread structure connectivity reductions, and generally structure connectivity progressively worsened as the disease progression increased. Okay. Then the next thing we looked at was the correlation with cognition. And firstly, for the default mode network, we found that increases in medial prefrontal cortex functional connectivity were associated with worse attention domain function. We also found that temporoparietal reductions in functional connectivity were associated with visual memory function, and both these associations were found in the non-CVD groups. And also, we found that temporoparietal reductions in functional connectivity associated with visual memory even in the CVD groups. However, in general, we found that default mode network functional connectivity associations with cognition primarily occurred in the non-CVD groups. For the executive control network functional connectivity, we found that reductions in the parietal functional connectivity were associated with attention, whereas increases in frontal functional connectivity were associated with executive function, both in the CVD groups. Here, instead, we found that executive network functional connectivity associations with cognition were primarily found in the CVD groups. So here we had a sort of divergence in terms of associations with cognition between CVD and non-CVD groups. We also looked at the associations between structure connectivity and cognition. However, we did not find a divergence, and generally, structure connectivity associations with cognition were quite similar across CVD and non-CVD groups. So, in summary, we used a multiple seed-based approach for functional and structure connectivity. We found distinct network functional connectivity phenotypes, underlying cognitive impairment in patients with and without cerebrovascular disease. We also found that for our structure connectivity, cerebrovascular disease presence in the brain tends to lead to early and more widespread reductions. And also, our findings provide further evidence on differential network phenotypes in Alzheimer's disease with and without cerebrovascular disease, possibly reflective of differential underlying pathology. And with this, I will end my presentation. Yes. I'd like to thank my mentor and supervisor, Dr. Helen Zhou, and all of my lab members at Duke NUS Medical School, our collaborators at the National University Hospital who provided us with the data, as well as our study participants and funding bodies. Please feel free to check out our lab website for the latest findings and also our lab posters at OHBM. Thank you.